Welcome to the FlightBridgeED Podcast series. Hey, welcome back, everybody. This is Eric. Today we're going to jump back into our podcast series. We did take about a 6-week hiatus for travel, summer months, just spending time with family. I'm currently building a house as well, so I've been extremely busy. So we appreciate your patience. We appreciate the continued following. We have seen our listener downloads, our listenership, subscribership just skyrocket in the last 6 to 8 months, and we're up to about 200,000 downloads in the first 2 years that we've been on the air. So we really appreciate that. That makes us feel like we're doing things right. As always, if you have ideas that we can better this program, ideas for case studies, things like that, always email me. Email is eric.bauer@flightbridgeed.com. And we will definitely look at all the ideas, and I'll put together some type of presentation. I'll probably contact you back to get an idea of the complete case. So we really appreciate that. Today we're going to jump into more of a learning lecture style content. We're not going to do a case study. I will bring different cases or different case ideas into this podcast. But one of the things that I see people really struggle with is the concept of the Oxyhemoglobin Dissociation Curve. When we teach the review classes throughout the country, one of the things that we do is we teach the course. It's 17, 18 lectures long, and we teach that course in a way that's called chunking. So I start off with concepts from the cellular level, oxygenation-wise, cellular activity-wise, ATP production, and we build on each single lecture throughout the 2-day course. The first lecture that we do is called Oxygenation Physiology, and it's a big lecture. It's a big lecture as far as content, as far as pathophysiology, and as far as just understanding the concepts. And it really takes a lot of people a while to get these concepts. So one of the big concepts is the Oxyhemoglobin Dissociation Curve, like I said. I've talked to many physicians, friends of mine, that say that this concept alone was a huge part of their medical boards when they became a doctor, that this concept is such an important aspect of managing your patients oxygenation-wise and critical care-wise that we really have to have a good understanding. There's a lot of questions related to this concept on the FPC and CFRN exams. You may just not realize it. So I really believe that understanding this concept and hopefully I can shed some light on some different resuscitation ideas related to this that will make you better clinicians. So we'll jump right in. Like I said, the Oxyhemoglobin Dissociation Curve is a concept that we look at based on oxygenation physiology and our hemoglobin. So essentially what the concept is we're looking at hemoglobin's affinity for oxygen or lack thereof or homeostasis. All right. So you have 3 separate curves. The first curve is a blue line, all right? So a blue line, and you have a X and Y axis. Your vertical axis is basically your hemoglobin concentration or saturation, all right? So your saturation, your oxygen that's bound to that hemoglobin. So it's your simple SaO2. Your horizontal axis is going to be your PO2. So this is a relationship between your SaO2 and your PO2 based on acidity or how alkalotic you are and different aspects related to acidosis and alkalosis. And we're going to discover different aspects of each one. As we've talked about in previous podcasts, one of the big aspects that we have to always think about is oxygenation and how we can improve oxygenation for our patients and provide good cellular activity. And we know that cellular activity is secondary to ATP production, and we have to have good oxygenation to have good ATP production. We know that ATP production is a result of glucose, a glucose molecule that's converted from glycogen. That glycogen is released from the liver from beta-2 stimulation. We start breaking down that glycogen to glucose, and we start with that glucose molecule, and the other ingredient we need for aerobic metabolism is oxygen. Now, I'm not going to get into the whole physiology of ATP production, but we just know that we have to have an oxygen-rich state. That's the ingredient that is lacking because our body's going to produce glycogen from any substance it can, even if it's sugar low, even if your body has low glucose, it's going to convert fats, proteins, carbohydrates to glycogen for purposes of ATP production and cellular activity. So this oxyhemoglobin dissociation curve is basically a concept that we have to look at our hemoglobin concentration and how that hemoglobin concentration is carrying oxygen. I've said it many times in podcasts, and I've said it in my review classes. If you look at everything that we can do to improve a patient's oxygenation state and cardiac output on a sick patient, one of the most important things to look at initially is a simple concept of just your H&H. If you don't have a proper H&H or a good H&H level, then you don't have oxygen carrying capacity, and your patient's already going to be suffering from that. So your hemoglobin is a huge player in how we transport oxygen, how we release oxygen, or how we don't release oxygen to our tissues. So that's the concept of this oxyhemoglobin dissociation curve. So for a normal patient, homeostasis, basically the relation between the two on a normal curve is if you had an oxygen saturation of about 82 to 85% on a patient that is normal, they're not acidotic yet, they're not alkalotic yet, your PO2 for that patient is going to be right around 50, 52. And we know that our PO2 norm is 80 to 100. All right, so that is just a standard thing. We know that a 82% sat is hypoxia, and our PO2 is going to be low as well. But we can survive at that range. We've also talked about previously that we have to have good ATP production. We have to have proper cellular activity and oxygenation to produce the right amount of CO2. And we've said that CO2 is a strong acid, along with sodium, along with chloride, and strong alkalis, things like that, lactate, that play into acid-base arrangements. So the concept of this oxyhemoglobin dissociation curve, is very simple in some concepts and very complex. So I'm going to try to make this as easy as possible. I've written kind of this corny little saying, and again, if you've been to my review classes, you've seen this. If you have one of our books, it's in the books. So a normal curve. This is kind of the corny little saying. The normal curve. Think of a normal curve as a manual for dating. In a normal relationship, you enjoy your partner's company, so you have a high affinity for them, but you don't mind dropping them off after an evening out because you know you'll see them again. So you have no jealousy. You have just a normal relationship. You have trust. And so basically your oxygen jumps onto your hemoglobin, and your hemoglobin says, okay, that's fine if you want to jump back off to your tissues for oxygenation purposes. That's a normal curve. So let's talk real quick about hemoglobin. Hemoglobin is a storage center for oxygen. And we've talked in previous podcasts that your oxygen that comes into your mouth has a starting PO2 of about 104 millimeters of mercury. As it travels down and it diffuses through your alveolar membrane into your capillary beds, it's going from a higher concentration to a lower concentration. From that higher concentration to that lower concentration, we go from 104 PO2. We have deoxygenated blood returning from the heart. That PO2 is about 40. So that is basically the diffusion of oxygen across that cellular membrane. All right. So we have to understand that is a constant process that is always happening. When we talk about anything that causes an excess, what causes a patient to become acidotic? Well, the first thing is maybe a diffusion issue, or are we getting enough oxygen diffusing through that alveolar membrane? And we know that if we start having anaerobic metabolism, we start having a patient that may be having a respiratory rate that's low, we start building CO2. If we start building CO2, being CO2 is an acid, we start dropping our pH. And we know that there's a correlation between our CO2 being an acid and our pH. So if you started with a pH of 7.40, which is a normal pH, and you have a CO2 of 40, which is a normal, perfect CO2, for every 10 points that CO2 increases, your pH is going to drop by 0.08. So if your CO2 jumps from 40 to 60, your pH is going to drop from a 7.4 to a 7.24, just based on the relationship of CO2 and pH. We've said it many, many times that oxygenation is the perfect ingredient to make sure that we have proper CO2 production. ATP production is normal. We're not going to build a whole bunch of CO2. So that's where we start looking at the second phase of this oxyhemoglobin dissociation curve, called a right shift. So we said that normal shift is homeostasis, and we said a right shift now is abnormal. A right shift on the hemoglobin curve basically is abnormal, but if you think about it from the context of oxygenation getting to your tissues, it's actually better for your patient in that regard. So the analogy is a right shift is right for your patient. So let's talk about the corny little saying, and then we'll jump into the physiology. A right shift on the hemoglobin curve means that there's a decreased affinity. So essentially, the hemoglobin does not want oxygen attached to it. Remember that hemoglobin has 4 seats on the hemoglobin molecule. So imagine a table with 4 chairs around it. In a normal, fully saturated hemoglobin, you may have 3 to 4 oxygen molecules attached to that hemoglobin or sitting around that table. But as you start building acid, you start adding hydrogen ions, you start adding a CO2, and so you go from 3 to 4 O2 molecules on there to maybe 1 oxygen molecule on there, and the other seats are accompanied or taken by the hydrogen and the CO2. Because we know in an acidotic state, our body is going to produce an abundance of hydrogen ions. So this corny little saying is decreased affinity. So basically your picker-outer is broken, so you tend to pick up duds, and your duds are far and few between. But they're duds, so you have no problem dropping them off after a night out. So again, a right shift is right for your patient. So how does this relate to our patients as far as oxygen delivery? Okay, like I said, we have that oxygen molecule coming down into our alveolar membrane. It diffuses across the capillary beds. At the capillary beds, we said that your hemoglobin is a storage center. And as it transports across that capillary bed, it goes to 2 places. The first thing it does is it dissolves in the plasma. Even though it dissolves in the plasma, only 2% of your oxygen is carried in the plasma. But your body uses the stores in your plasma, right? It only is 2% of the whole amount of oxygen that's delivered per minute, which is about 1,000 mils per minute in a normal, healthy person. So only 2% of that is getting into the plasma. Your body utilizes that plasma concentration for purposes of oxygenation throughout your body. And your hemoglobin is the storage center for those oxygen molecules. So it's just kind of all those hemoglobin are floating around, and it's got all these O2 reserves stored on it. And in purposes of a patient or a person that's needing a high amount of oxygen, they're requiring a huge demand, then your body will start pulling from the hemoglobin and utilizing that O2. So when we look at a right shift, there's different reasons why your patient is a right shift on the hemoglobin curve that causes that decreased affinity. And the biggest one is an acidosis. Okay, so when we have an acidosis, we said that the primary initial cause of an acidosis is most of the time CO2 production being in hyperdrive. Why is it in hyperdrive? Well, we said that in an anaerobic state, we said in an aerobic state we need glucose and oxygen. And that whole process goes from glycolysis to the Krebs cycle to the electron transport chain. It produces 38 ATP molecules, with 36 being the final result, because we have to utilize 2 ATP for that whole chemical process. But in an anaerobic state, we have glycolysis, we have the splitting of the pyruvate, and at that point we instead of producing acetyl-CoA and producing the ingredients to move towards the electron transport chain, the NADHs and the FADHs, we don't have that O2 molecule to cause or help with that chemical process. So at that point, your body says, well, I don't have that ingredient, so instead, now those pyruvate split off, and you produce CO2, and you produce ethanol, and different byproducts like that. So that process is completely done, and then we start that process again. The Krebs cycle in this whole process is a very fast process. It's kind of a mediary point. So we start back again, and we do the same thing. We split the sugar into pyruvate. We go into the Krebs cycle. We're trying to look for that oxygen molecule to start splitting that and utilizing the chemical reaction that we need to move to the electron transport chain, but we don't have that. So again, we produce CO2, ethanol, lactic acidosis, or lactic acid, I should say, and we start that process again. So that process is in hyperdrive. So that's why in an oxygen deficient state, we produce an abundance of CO2. In comparison to a normal aerobic state where you still produce CO2 from the splitting of the pyruvate and acetyl-CoA, but it's in a normal amount. It's a slow process. So that's where we can keep up. Our body can metabolize that and burn it off or utilize it how it needs to. So that's where a right shift comes in. So we have an abundance of CO2. It starts driving your pH down. We become acidotic. Because of this is where it causes a decreased affinity for oxygen. So what your body will do is now your hemoglobin doesn't want the O2 on there. It doesn't have enough seats, like I said. It's got the hydrogen attached to it, it's got the CO2 attached to it, and maybe one O2 molecule. So only one of the 4 seats is accompanied or has an O2 molecule attached to it. And instead, now it dumps those O2 molecules off to the tissues. Okay? So because of this, your PO2, if you check a blood gas, is going to be through the roof. We said a PO2 normal is 80 to 100, and in this regard, your PO2 may be 200, maybe 300, maybe 400, because all of our O2 that should be stored on that hemoglobin is now being dumped to our tissues. So that's where you can say a right shift is right for your patient, because your patient cellularly is getting very, very large amounts of oxygen diffused to it. So if the hemoglobin molecule now is dumping all of its stores to our tissues, and our one trending tool that we've used for years is our saturation, our SaO2. And your SaO2 is a measurement of hemoglobin saturation. In this type of patient, your O2 saturations are going to be lower than normal. So that's why you always hear me say that I feel like an SaO2 leads us wrong. We should not be tunnel vision using that. We should be looking at the whole patient, look at the critical care aspect of it, and identify, is this patient an acidosis? Is their pH really low? Do they have a huge amount of CO2? If so, is an 88% oxygen saturation, is that a bad thing, or is that just a result of this process right here? And I'm going to use a scenario here coming up that's going to kind of illustrate this. Some other reasons why we build acid and build this decreased affinity. Raised temperature. Well, in raised temperature, a lot of times you start having an acidosis. So raised temperature. So you can think of right shift as anything raised. Raised temperature, raised acid, raised 2,3-DPG. All right, so 2,3-DPG, a lot of you may know what this is. Basically what this is a molecule that's attached to and works closely with your hemoglobin molecule. And essentially it's a crowbar that pops off the oxygen when it needs to be utilized to the tissues. So in a normal healthy adult, homeostasis, you have no affinity issues, you're a normal shift on the curve. This 2,3-DPG is in normal amounts, and when your body needs oxygen released from the hemoglobin, that molecule will pop off the oxygen, and then your body can utilize that for purposes of cellular function. So raised 2,3-DPG. Why would somebody have raised 2,3-DPG? Well, the big patient that we see all the time is a patient that's COPD, and they're polycythemic. And polycythemic means that COPD patients produce an overabundance of red blood cells because of the whole process of they live at a very high CO2 rate. They build a lot of hydrogen ions, and then because of the breakdown of CO2 and hydrogen to bicarb and the free amount that's floating in the blood, they start producing an abundance of 2,3-DPG because of that. And the end result is a raised PO2, like I said. So raised temperature, raised acid, raised 2,3-DPG, and raised PO2. The other patients that will have a raised 2,3-DPG is anybody that lives at a high altitude. So, the people, you may be listening from Denver. You may be listening from Arizona, maybe from Wyoming. Those of you that live at those high altitudes have a higher amount of red blood cells, and because of that, you have a higher amount of 2,3-DPG. That's why athletes that want to build up their endurance, marathon runners, cyclists, things like that, triathletes, they will train at high altitudes to produce an increase in red blood cells and thus increased 2,3-DPG so they can utilize that oxygen much, much easier. Okay, so right shift, decreased affinity, and we look at this from a perspective of this is right for the patient. So I'm going to give you a little bit of a scenario, and then that's going to lead us into the left shift on this curve. One of the things you all may know about me is I'm very, very passionate about ventilator management, and over the years I've mastered that subject. I've worked very, very hard. I've worked closely with a lot of different people to become very proficient in that subject, and I feel like it's a deficiency nationwide as far as air medical transport goes, and so it's kind of my goal to bring that education up across the country to a level where we can really deal with our patients at a high level. So one of the things that I've seen, I've talked to a lot of clinicians, I've talked to a lot of crew members about this, is you have a patient, let's say, that you're flying, you're not real confident with a ventilator, and you notice that your patient's O2 sat is approximately 88%, and their end-tidal CO2 is 55. And you're flying along and you're trying different things to improve their oxygen saturation, and you've increased their FiO2 up, you've added some PEEP to your patient, and your O2 sat is still 88, 89%. You've also tried to manipulate the minute ventilation a little bit. You've tried different things with your IDE ratio, and you really can't get that end-tidal CO2 to drop down. So you get frustrated. And again, I've seen this many times. So you kind of say, you know what? I don't want to get in trouble. I want to make sure my numbers are where they need to be. And this just comes with experience. And so you say, you know what? I want my end-tidal CO2 to be 35 to 45, and I want my O2 sat to be 92 to 94%. And you're really stuck on that. And you kind of get tunnel vision. You don't look at the whole big picture. You don't maybe understand this concept, and that's why I'm presenting this. And so what do? You take them off the ventilator and you go back to what you know, and you start bagging your patient. Well, any of us that bag our patients have a big possibility of hyperventilating our patients. We bag too fast. We see it all the time. Well, if you start bagging too fast, what do? Well, just by bagging too fast, we start blowing off the CO2. We don't realize we're doing it. So you start seeing that CO2 drop down. Right? And so you start seeing that CO2 drop down, you're bagging your patient, and as that CO2 starts dropping down, you're starting to get into the 40s, and now you're about 45, and you're 40. All of a sudden, you start seeing that O2 sat come up, and all of a sudden, your oxygen saturation is now 92%. And what do you think? You're like, holy cow, I just did perfect for my patient. I've brought their end-tidal CO2 down to a normal range. I increased their oxygen saturation to a normal range, and I didn't need the ventilator to do that. So what have we done? All right, so let's talk about that. So we're going to leave this. You think about that. Think about that concept, and we're going to jump into the next aspect, which is a left shift on the hemoglobin curve. So a left shift on the oxyhemoglobin curve. This is the corny saying. You now have an increased affinity. So you really like this person you're dating. You have a high affinity for them, but you're not secure in your relationship, so you're reluctant to let them go very easy. You have good pickup, so your hemoglobin is picking up the O2 molecules, but you have very poor drop-off. So this is a bad thing. So now what you have is you have a situation where your hemoglobin has all of these O2 attached to it. So now you have 4 seats around your hemoglobin table, and all 4 seats are completely filled with O2. You have no hydrogen, you have no CO2, you have no bicarb, you have nothing. You have nothing on them. So let's talk about why. Well, low temperature. So anything low. So low temperature, low acid, all right? So we have too much base now. We're in an alkalotic state, so alkalosis. Low amounts of 2,3-DPG. We're going to jump into another scenario in a few minutes. I'll explain that concept. Low PO2. So the end result is a low PO2. All right, so let's look at this. If now we have too much oxygen attached to our hemoglobin, and our hemoglobin is now hoarding that, what do you think your oxygen saturation is going to be? Well, it's going to be very, very high. So now you went from a acidotic state, a right shift, where your O2 saturation is low because your hemoglobin is dumping all of its stores off, to now we have a hemoglobin that has all these O2 molecules attached to it, and now we have a very high O2 sat. So again, this is why I say don't get sucked into an O2 sat, because it really doesn't tell you the big picture. All right, so we also look at this and we have a low amount of acid. All right, so a low amount of CO2. So let's go back to this scenario. We've bagged our patient. We've dropped their end-tidal CO2 from 55 now. We're down to 35. We're in that normal range, and by doing that, we've brought their O2 sat up, and we now think that our patient is doing perfect. We fixed our patient. But in actuality, what have we done? We went from a right shift on the hemoglobin curve. We were in an acidotic state. We had a CO2 of 55, and just by the relationship, like I said, a normal pH of 7.40 and a normal CO2, for every 10 millimeters you increase on that CO2, you're going to drop your pH by 0.08. So if you had a CO2 of 55, what was your pH? Well, it's going to be around 7.26, 7.27, so it's abnormal. It's acidotic. So we went from that to where we have good amount of oxygen dumping to our tissues. We have good cellular oxygenation, which really allows great cellular ATP production, right? It's hyperdynamic. To now what we've done by just bagging our patient too fast, because we all do this, we've now blown off all the acid. We've gotten rid of all the acid. And by doing that, now we've raised that pH up from an acidotic state to an alkalotic state. Okay, so we've shifted that curve from a right shift now to a left shift. A left shift is a very bad thing. So that's why our O2 sat came up, because we talked about the relationship. Now we have an increased affinity. Now what we have is we have all those O2 molecules attached. So of course your oxygen saturation based on hemoglobin concentration is going to be high. We have a low CO2, or a CO2 that's lower than what we had, because we've blown it off, right? Low acid. Well, what is the end result now? If you have a increased affinity of hemoglobin, or oxygen to hemoglobin, and we have a really high oxygen saturation, and if you didn't understand this concept, you would think your patient is getting great oxygenation. But in reality, what you've done is you've caused a situation where your hemoglobin is hoarding all those O2 molecules. You have a patient that's in a hyperdynamic state, right? We fly patients that are sick, right? We're not talking about a patient here in homeostasis that's perfectly fine. We're talking a patient that needs a lot of oxygen, that needs, an increased amount, whether they're septic, whatever it is, trauma patient. And you now have caused an issue where there's not enough oxygen. Your body's using up all of the O2 in the plasma, which is only 2%, and it's looking for oxygen to be pulled from that hemoglobin, but the hemoglobin won't let it go. So what happens cellularly? Well, we have no O2 to dump to the tissue, so now we are cellularly hypoxic, and we're going to start having an anaerobic state. Does that make sense? So basically what you've done is you've caused a great O2 sat. What you see on the monitor makes you feel good, because you see a good O2 sat, you see a good end-tidal CO2, but in actuality, based on the patient's condition regarding acidosis and alkalosis and the oxyhemoglobin dissociation curve, what you've done is you've made the patient worse. So how do we correct this? What do we do in that situation? Again, when I explain stuff like this to you, I want you to go off your protocols. But my goal is for you to critically think and to think outside the box and understand that not everything is black and white. We can't be cookbook clinicians. Protocols, depending on where you're flying at, are guidelines. And you should be able to move between different protocols and use clinical, critical care judgment to make good decisions for your patients. So for me, for the company I'm flying with, I would absolutely let that patient have an 88, 89% O2 sat, and I would let them have an end-tidal CO2 of 55 if I understood that they had an acidosis and a right shift on the hemoglobin curve, because I know the patient is better off than for me to really try to mess with this whole concept of shifting and affinity for oxygen on the hemoglobin. So for me, I would let that ride. I wouldn't do anything drastic. I would understand that this is better for my patient, and I would document this in my chart. I would document my critical thinking skills of why I left this the way it is. Okay, so let's jump back to the oxyhemoglobin dissociation curve and a right shift. There's two concepts I want you to understand. There's two definitions that go along with this. The first one is called Bohr effect, and basically Bohr effect is the definition of a right shift on the hemoglobin curve. Remember, a right shift is a hemoglobin that has less affinity for O2. So you have a huge amount dumping to your tissues, you have a very low amount attached to your hemoglobin, and because of this, your O2 sat may be a little bit lower than normal, and you're going to be in an acidotic state. So Bohr effect states that hemoglobin oxygen binding affinity is inversely related both to the acidity and the concentration of carbon dioxide. All right? So, two things I just explained. To the acidity and to the concentration of carbon dioxide. Well, we said in a situation where you have a huge amount of CO2 production, you have a patient that has a decreased amount of oxygen, they're hyperdynamic, they may be sepsis patient, you're going to have a huge amount of acid built up. That's going to drive that pH down, so that's where that acidosis comes in, and that's what basically causes that phenomenon. The next part of this is called Haldane effect. Haldane effect describes how oxygen concentrations determine hemoglobin's affinity for carbon dioxide. For example, high oxygen concentrations enhance the unloading of carbon dioxide. So what that means is, when we have a huge amount of CO2 that's building up, we have an acidotic state. Just by providing good quality oxygenation, whether it's you intubating your patient, putting them on the ventilator, using good strategies, ventilation strategies, that's going to improve the patient. That's going to improve the patient, and things need to happen slowly. But what it's going to do is it's going to start unloading that CO2 that's attached to the hemoglobin molecule. We said that we have a huge amount of CO2 production, so you have an acidotic state. And by using good oxygenation strategies, just by your good care, you're going to start unloading CO2 and you're going to start correcting that issue. So those are the main two big definitions for a right curve. All right, so let's go back to, we've talked about a normal curve, we've talked about a right shift, we've talked about a left shift, we've talked about the issue of not doing anything drastic as far as having a patient with a little bit of a low O2 sat and a high CO2 to understand the concept and not just toss the ventilator and start bagging our patient, to trust the ventilator, trust and work with the ventilator and become good with the strategies. The last thing I want to cover is a left shift on the hemoglobin curve, and I said that we'll come back to it, a scenario of low 2,3 DPG. In the industry right now, there's a big push on massive transfusion, and we've learned that giving excess amounts of fluid, whether it's in trauma, burns, sepsis, anything, is really detrimental to our patients. And a lot of times our patients die from secondary issues like DSE, rhabdo, things like that. And in trauma, what we're seeing that paradigm change where we are starting to give FFP in flight. We're starting to give tranexamic acid, TXA, in flight for patients that could have massive transfusion. Okay, so let's say that we have a patient we're flying, and we determine that they need massive transfusion. They've got multiple system trauma, chest, abdomen, pelvis, so they've lost a lot of blood. We've learned that permissive hypotension is the best thing we can do. We want to just maintain a map pressure that's going to perfuse the brain. And so without a head injury, we're wanting to keep that map about 65. And with a head injury, because of the increased ICP and our cerebral perfusion pressure needs of being at 70, we need to have a map a little bit higher. So a trauma patient with a head injury, we need to have that map at least 90. For a trauma patient without a head injury, we keep that map about 65. But that's it. So if that means your blood pressure is below 90 systolic, then that's all right. Don't get tore up about that. Look at a map, look at the patient, permissive hypotension. So the reason why I wanted to talk to you about this is because we need to think about resuscitating our patients completely. And what I mean by that is resuscitation oxygenation-wise. And here's the reason why. When you start giving massive amounts of packed red blood cells, remember, packed red blood cells are something that have additives into it. So they have citrate, just to keep that blood. In the military setting, in Iraq and Afghanistan, they can actually have patients, or I should say soldiers, sit down and give whole blood, and they can transfuse whole blood instantly, which is great. But in the civilian setting, we can't do that. So we have packed red blood cells. We have citrate in that packed red blood cells. And we know that citrate in the packed red blood cells starts binding with calcium, binding with magnesium. We start having a decrease in calcium levels, so our patients become deficient in calcium. So we have to always be thinking about that we may need to be pushing some calcium gluconate on these trauma patients. We maybe need to replace the mag. And if you always have a low calcium, you're going to have a high phosphate. So remember, calcium and phosphate have a inverse relationship. If your calcium goes low, your phosphate's going to go high, and vice versa. Well, what else the citrate does is it starts destroying the 2,3-DPG. And we said that 2,3-DPG is essential for your body to utilize the oxygen that's on the hemoglobin. So in a right shift, we said that is a great thing, that's even though you have a high amount of 2,3-DPG and you have a high amount of O2 that's being dumped to your tissues, it's because of that phenomenon. It's because there's so many 2,3-DPG out there, it's dumping all that oxygen to the tissues. Well, in a left shift, we said we have low 2,3-DPG. So we already have a situation where we have an affinity issue. We have a hemoglobin that's hoarding the O2, but now we have 2,3-DPG that's deficient as well. So you have a trauma patient that has an issue. They're probably already in a deficient oxygen state. So they're probably on the acidotic side. So this is where we have to understand that when you start giving these massive transfusion protocols, you start decreasing the levels of 2,3-DPG because the citrate starts killing it. So what's that going to cause? Well, that's going to cause a patient to go from a right shift, which is something that can happen to every patient, right? We mostly see our patients go to a right shift. We mostly see our patients in an acidotic state. I would say, every 8 out of 10 for me that I see flying is an acidosis that has that phenomenon, a metabolic derangement. When we look at the concept of this, we have a low amount of 2,3-DPG, so now we can't utilize the O2. We can't take the O2 molecules off the hemoglobin for use for cellular activity. So that's why we have to be very, very careful with our trauma patients to make sure that we're resuscitating them fully as far as oxygenation wise. So that's where maybe intubating these patients, putting them on the ventilator, and optimizing oxygenation with FiO2 and PEEP and recruitment is going to be best for that phenomenon of massive transfusion because of the loss of the 2,3-DPG. Now, you don't have that problem with whole blood. If you're transfusing whole blood, you don't have that issue. But for this issue in the civilian world where we're using packed red blood cells, we're losing the calcium, we're losing the 2,3-DPG, we have to resuscitate completely. Okay, well, that's all I have for Oxyhemoglobin Dissociation Curve. If you have any questions on these concepts, please email me. Again, it's eric.bauer@FlightBridgeED.com. We really appreciate everybody. We appreciate all the kind words, the emails, the phone calls I get. Anything you need help with, let me know. If you're still studying for your FPC or CFRN, remember we have some great products. We feel are industry leading. We're selling a lot of books every single month, and we want to thank you for that. If you're looking for a review class in your area, just contact me. We can try to see what we can do. And we just thank you so much, and we'll talk to you soon. We want to thank you for following FlightBridgeED.